So good evening, respected faculty, esteemed colleagues, and dear friends. It gives me immense pleasure to welcome you all for this very special session, Keep an Eye on the Heart. As ophthalmologists, we often say that the eye is a window to systemic health. Today, we extend that philosophy further, recognizing that caring for the heart is equally vital to preserving the healer behind the microscope. Our profession demands precision, endurance, and intense concentration. Yet, in the midst of caring for countless patients, we often overlook our own well-being. Cardiovascular health remains one of the most important determinants of longevity, quality of life, and professional sustainability. Awareness, prevention, and timely intervention can make a profound difference not only for our patients but for ourselves. It's truly an honor to have with us an eminent preventive interventional cardiologist, Dr. D. Prabhakar, who will share valuable insights on protecting and strengthening our most vital organ. I also thank our distinguished panelists, Dr. N. Kasinathan, Dr. Raj Anand, and our convener, Dr. Arvind, for bringing together these meaningful and relevant discussions. My heartfelt gratitude to Dr. DC for curating this wonderful program. At TNOA, we believe that progress in medicine is not only about advancing knowledge and surgical skills, but also about nurturing healthier professionals and a stronger medical community. Today's session reflects that commitment, reminding us that a healthy doctor is a foundation of healthy patients. I encourage all of you to actively engage, ask questions, and take away practical steps that can positively impact your life and practice. Thank you all for your presence and participation.
Madam, thank you so much. We have been having a wonderful 7 months with different types of international, state, and local programs, and variety of topics is going on fine. I'm sure we are going to have many viewerships for this also. So, thank you, Dr. Prabhakar, for coming and trying to give us all the insights about our own heart, if at all it is there. And next, I'd like to thank Arvind, who designed this program and got two good experts to ask questions. And Dr. Ravi Shankar, sir, Chairman ARC, welcome, sir. Welcome to the program. Now, I'd like to invite our past president, Dr. Nirmal Frederick, who's also the classmate of Dr. Prabhakar, to give a short intro about Prabhakar before we hand over to Arvind. Dr. Vijayaraghavan, sir, who is the president-elect, welcome, sir. So, over to you, Nirmal.
Thank you, Chandru. And so good evening, everyone. And first, a word of appreciation to our president for doing a wonderful job and steering this One Vision, One Legacy. And also continuing some of the wonderful program we initiated in the yesterday years. And this Fitness for All is one such initiative which has done wonderfully well with our compliments to our convener, Dr. Arvind, for putting together this program as well as continuing the initiative with so many new thought process. So now to tonight's theme, Keep an Eye on the Heart, a perfect reminder that behind every pair of eyes we treat, there is also a heart that needs looking after too. That is our heart. And of course, our patient's heart. We are used to checking that heart more than our heart. So, you know, they say the eyes are the windows to the soul, but heart is the engine room. So we have mastered the window. So tonight, let's speak into the engine room. And to help with that, we have someone I'm proud to call not only as a colleague, but also a long-term buddy, my Madras Medical College classmate, Dr. D. Prabhakar. Starting from the anatomy halls, we have continued our friendship for the last 40 plus years. And our bond goes much deeper into the family. So not sure how many of you know that Prabhu is a sibling of Dr. D. Chandrasekhar, our own General Secretary. And I have the privilege of knowing all the three siblings. Dr. Chitra, who's also an ophthalmologist and entrepreneur, who's a close friend. So growing up with all these three kids, siblings, and enjoying the warmth and protection of their distinguished DGP father during the college days, I can tell you these three fellows are a special breed. So now to his credential speaks volume, other than being good pals. He has collected a lot of degrees and the designations. So it goes into pages, but I'll just highlight some of the things that you've been doing. Is a preventive interventional cardiologist. So I think that is an antonym by itself. Once you prevent and then you intervene, or you intervene and prevent. I'm not sure about this, Prabhakar. So he is a cardiologist at Ashwin Clinic, named after his elder son, who also happens to be our dancing partner in our batch meets. He is a professional member of the European Society of Cardiology, president of Chennai Chapter Cardiological Society of India, president of the State Chapter Lipid Association of India, and heads of many other committees like Indian Society of Hypertension, core committee of the Heart Failure Association of India. So I would like to see him as the president of the opposite, joining the hearts. So beyond all these titles, Prabhakar is a multi-talented person, equally at ease discussing ejection fraction or setting the dance floor on fire with moves that rival his angioplasty skills. So tonight, let's combine the two, the eye and cardiology combination. So we ophthalmologists dilate pupils, cardiologists dilate arteries. So tonight, let's dilate our minds and see what he has to tell us. So with these few words, I welcome my friend and one of the finest hearts I know. Please join me in welcoming Dr. D. Prabhakar. So over to you, Prabhakar. Happy to have you here.
Thank you, Nirmal. First of all, I should say that Chandrasekhar wanted to say whether everybody's got an heart. Everybody has to have an heart. And whether it is good or bad is a question that we will discuss and find out how good and bad hearts are. And thanks to Dr. Arvind, Chandrasekhar, Nirmal, and Dr. Sujata for having me with all of you people. It looks like a very, very organized program with a lot of forethought and idea of preventing subsequent problems. I think it's an amazing thing. I wish we cardiologists could do this for ourselves, because there's so many of these young cardiologists who get into trouble because of all the stress that happens to all of us.
Prabhu,
And,
one second, can I intervene?
Yeah, go ahead.
We'll ask Arvind to give a short intro about the panelists before we proceed.
Go ahead.
Arvind, over to you, Arvind.
Thank you, sir. Thank you, President Madam Sujata Mohan, for this unique opportunity where we focus on not just the health of our patients, but the health of our fellow physicians. Thank you to Dr. Chandrasekhar for actually conceptualizing this program and making the time and the infrastructure to get this on. I'm going to just share with you a very small PowerPoint presentation. Can you see my screen?
I can only see a couple.
Yeah.
Okay. You got to go for a presentation.
Yeah, I've gone to the slideshow mode. I hope the slideshow is visible now.
Yeah.
Yes, visible.
So this is the 8th in our series of webinars that we have been conducting through this novel program called FFA. For ophthalmologists, FFA means fundus fluorescent angiography, but we renamed this acronym to say Fitness for All, which we thought is very apt because fitness is a democratic right. Everybody has a right to fitness, not just the people with six packs or large biceps, not just the people who do a lot of activity, but as a basic right, what is the most minimum stuff that we should do to stay healthy and fit? We are endowed with a body, and it is, of course, our responsibility through our lifetime to take this through. And more so, I think as doctors, we already have the shortest of life expectancy among most professionals. Why is this so? Why can't doctors be the fittest of all? And why can't we take a few steps in those directions? That's probably the core idea with which we came up with this program. And as of now, Fitness for All is a multifaceted entity. We do yoga workshops, we do online programs, we've conducted 2 treks, and we conduct a lot of these webinars to exchange ideas about the concept of health. And so in this series, I'm very happy to have Dr. Prabhakar share his expertise and his time with us. This is going to be a very quick question and answer session. We are going to shoot questions, and Dr. Prabhakar, and he, with his excellent wit and timely responses, is going to give us the best of medical cardiac science that we have right now. It's giving me a great privilege to invite these two panelists who have actually taken the time to be with us. There's a very special reason both of them are there, other than the fact that they are very successful senior ophthalmologists. Dr. Raj Anand is a senior oculoplastic colleague practicing in New Delhi. And Dr. Kasinathan is, of course, very well known in TNOA. He's an independent private practitioner, a vitreoretinal surgeon, also the uh, head of several societies. And both of them, charming, young, fit people who have a story very close to their heart, which will eventually come to. Thank you, panelists, for being with us and being open to sharing this story. I'm going to stop sharing my screen. And so, Prabhakar sir, I'm going to throw the first ball. I hope you are ready.
I'm always ready, Shiva. Or if you say Tamil Nadu, Srikanth.
Here comes the Yorker. I also welcome all the people who have joined us live to be in this webinar. If you have questions, please drop them in the message box, in the chat box, and we will ask them to Dr. Prabhakar. So, sir, every time we hear a young person losing their life in a gym, in a dance party, or doing something which was supposed to be fun, our hearts go to them. We think that that particular activity which they did is what caused the death. So, what is sudden cardiac death? Is it increasing among young people? Do we have a pandemic of sudden death suddenly, which wasn't there before?
So the sudden cardiac death is something that is both hyped and underrated. Truthfully speaking, sudden cardiac death is there. All of us have seen friends die. In fact, there was a doctor who just collapsed on a stage in a wedding some time back. I have had my own colleagues dying. And my colleague who was highly stressed out just went for a walk and just died. And there are so many doctors. Every 2-3 months, you get one news of condolence of a doctor dying. Apart from that, you have these people dying in gyms, people dying while they are walking, jogging, everything keeps happening. I think the story is very simple. Before you start any strenuous exercise, at least have a basic cardiac checkup done. And if you look at when to start, that is going to be the first question. When should you start screening? I think any adult who's more than 18 years should have at least one basic checkup done. And in fact, I was instrumental in writing the Lipidization of India guidelines at saying, when you enter college at around 18, you should have a basic blood pressure and a non-fasting lipid profile. It doesn't have to be fasting. You just get an idea of what you're expecting. If possible, try to get an ECG also. Because among all the things that you said about sudden cardiac death and people dying suddenly, among doctors and people just suddenly dropping dead, the biggest marker is the electrocardiogram. Basic ECG does show some markers and it really helps to find out what happens. And there is something like family history. You had somebody in your family dying of, be careful. Check yourself. There's a lot of things in genetics that we ignore. I'm sure all of us are aware that all diseases are genetic. Like if you and I have a cold, we both behave differently. Why? Because our genetic makeup is different. It's the same for every disease. And sudden cardiac death is no different disease. So basically, we tend to ignore symptoms. Like if you're 30 and you walk or you jog, at that point you have some discomfort. You try to pass it up by saying that I'm not trained enough. I just want to ignore it. Please don't ignore anything. Stop. Take your time and don't try to overdo anything in life. I think that should be the simplest motto. Prevention of other disease, I will come to if you are coming to the questions later. But as far as sudden cardiac death is concerned, it is there. It is there to a very large extent. And there are a lot of markers for sudden cardiac death. You want me to expand on that? I can give you simple examples. Puneet Rajkumar died. And when he died, there was a big spurt of questions and answers on sudden cardiac death. People started saying, should we go to the gym? Are we exercising? Now, a couple of things about going to a gym and exercising. Beyond 1 hour, don't try to do anything. 1 hour is fair enough time for any exercise. Even if you're walking or jogging, whatever. If you're walking, 1 hour of exercise is more than sufficient. Beyond 1 hour, actually, the benefits are not there. Cardiac benefits are not there. You might lose weight, you might become Mr. India. All that is fine. But who wants to become Mr. India? Unless Nirmal wants to become Mr. Aftal Chennai, I don't think it's going to be there. Arvind is looking so fit that I will think that he's probably trying to get a new girlfriend. If you have something like that, it's a different story. But I don't think it should be like that. 1 hour of exercise is fair enough, and it has to be a comprehensive exercise. The most common mistake we do is hydrating yourself. Hydrate well. If you hydrate yourself, half the problems are solved. The second important thing is if you have a drink. This is something that people totally ignore. If you have a drink or two, give a minimum of 2 hours following a drink before you exercise, because drink can be detrimental. Drink can dehydrate you. This is something that is never spoken, never discussed. But if you have had a drink the previous night, or if you had about 4 or 5 drinks in your previous conference that you have gone for and had a big party at night, next day morning before you start exercising, please make sure that you have taken at least 2 hours per drink, hydrated yourself well before exercising. Nutrition, exercise, everything is all pretty important. I will not go too much into that at this point of time.
Thank you, sir. I think you took multiple shots with that single ball, but you did bring in a lot of pertinent points, which are going to be the nidus for my further questions. And like I said, like you said, the first question is going to be, how early do you start screening for a cardiac issue? And like you said, 18, which is probably pretty alarming, because most people used to think 40s, 50s la pannikla. That's when you actually consider yourself old. But I guess the new cutoff would be age 18, and that should be a marker for most of us. Like you said, maybe a BP and ECG should be a startup. But at what point of time would you suggest something more specific, like a cardiac CT or an angiogram or a treadmill test? Which among these would you place more weightage on at what age?
I think you've gone a little too far from 18 for a cardiac CT or a CT coronary angiogram. That's not in the picture at all. So the next question actually logically should be, why do you start screening at 18? Why should you start screening at 18? In fact, the incidence of familial hypercholesteremia is something like 1 in 500 in India. And in India, familial hypercholesteremia is when your LDL cholesterol is more than 190 by Western standards. By Indian standards, it's even 160. There is a very good news among the UK Biobank data. UK Biobank data said Indians have an LDL cholesterol which is 10 milligram lower than the Western population. That's good for all of us. But unfortunately, it also goes to the next statement, which says we get coronary artery disease 10 years earlier. So basically, it just means we have a lower cholesterol, but we are more prone genetically for coronary artery disease. So we have to start looking early. In fact, when we started the guidelines for lipid association of India in 2016, I went ahead and said, all Indians more than 40 years must be started on a statin. There was a big hue and cry. Everybody was like scandalized. Then I gave a justification, the cost implication for that, because generic 10 milligram atorvastatin will cost you just 2 rupees. A rosuvastatin will cost you 1.5 rupees. In fact, you can get a 40 milligram rosuvastatin for 5 rupees in the current government shops. So it is all possible. But do you need it? That is the big question. So the reason why we start early, screening early is, one, you can institute lifestyle modification. Second, more importantly, all of you should understand one thing. There is something called plaque burden or a cumulative incidence of heart disease. What it means is, let's say you're 40 years of age. Your LDL cholesterol is 150. Your plaque burden or lifetime burden is something like 40 into 150, which is going to be about 6,000. I hope my maths is correct.
You just
6,000.
more, sir.
6,000.
6,000. So 150 milligrams, and then you look at a plaque burden of 150 for 40 years. Your lifetime plaque burden is 6,000. Now, each of you, if you know your lipid profile, please calculate this and remember this. At 5,000, coronary artery disease starts. And most of the time, at 7,000, it manifests. So if you don't catch them by 18, 20, start reducing a lifetime burden, you are going to land up with a problem earlier in life. So if you have 200, you reach the target much earlier. If you have 100, imagine when you're going to get it. It's going to take about 40 years, 50 years to start getting to the 5,000. So it's going to take much, much longer. I'm very poor in maths, but you can start looking at it. Now, this applies not only to cholesterol, it applies to hypertension, it applies to blood sugars, about which we'll discuss later, about the sugar and the total cholesterol. And the blood pressure, I can talk about it separately. So you start screening early and start controlling your risk factors. You reduce the total burden. Basically, if you look at a block or a plaque, what does it contain? It contains cholesterol and oxidized cholesterol. So you don't have to really go too much into it. You just remember that the excess goes and gets deposited there. So if you get it down, there can be a reverse cholesterol transport and can start happening. That's the simplest method. If you want me to talk about your coronary artery calcium score and your coronary CT coronary angiogram, Now you must understand it takes time. What is the coronary artery calcium? Coronary artery calcium is nothing but a marker for atherosclerosis. So if you have a block and that gets calcified, you get it. So it is not mandatory. You can have a block without calcium. So coronary artery calcium score is not a must to have coronary artery disease. And in fact, it has been proven scientifically that younger persons have a calcium score of 0, but when the plaque burden, which is what I meant by the total lifetime burden, is high, they still get a heart attack. And that is not determined only by this. There are several other factors which make these blocks unstable and they promote a myocardial infarction. One of which is going to be smoking, your shearing stress, sudden exercise, and all these persons with mild coronary artery disease who have a sudden arrest during an exercise. You don't warm up and do an exercise, the plaque is not prepared to take the exercise, the plaque becomes unstable, exposes the lipid core, it promotes thrombosis, you have a myocardial infarction, just drop down dead. So these are several factors. So when should you screen? If you're 40 plus, I will suggest you can do a screening. Fair enough. But 50 plus, you have some benefit of it. But beyond 40 in India, if your cholesterol is high, please start statins. Nothing wrong in taking statins. All the side effects you can, if you want, you can ask me later. I can talk because one of my favorite topics is statin intolerance, and you can ask me about it. But should you do a CT coronary angiogram? Not required. If you get all your risk factors controlled, it's fair enough. You don't need to do an angiogram unless you're having a symptom.
Right, sir. I'll leave the therapeutics to you. So I'll come down to some basic doubts that most professionals have. All doctors have mostly no time for exercise. But there is a minimum time we always say that you can contribute to your physical health. So what is the basic minimum definition of exercise you would recommend to busy professionals?
So see, basically the American Heart Association came up with this answer and said that if you do about 150 minutes of walking, brisk walking every week, it's fair enough. If you're jogging, 75 minutes. Now, how it has to be split is 30 minutes for 5 days. So minimum of 150 minutes of walking. Or if you're going to be jogging, 25 minutes for 3 days. 75 minutes is fair enough. But there's another important aspect to it that is in the footnotes, which people don't read, is that 2 days of weight training for everybody. Build up your muscle strength, which is also equally important. To prevent, this is fair enough. But if you have a heart disease or if you have hypertension, this extends to 40 minutes minimum per day. Now, the question that people ask about exercise is, I am growing old, I have joint pain, this, that, everything. Now, there are a lot of these other exercises which don't involve your knees. You can do all these strengthening exercises. Off late, the most popular one seems to be the Tai Chi. I'm sure all of you have seen enough Tai Chi on Instagram and all these YouTube posts. It's all fairly simple. You can do it anytime you want. It's a much more composite exercise with the all-round body exercise. You can do any form of physical activity. Everything works. I think it's fair enough to say 150 minutes per week is good enough.
So on the other extreme, we have marathoners, ultra marathoners, Ironman, all in our group, all are ophthalmologists, and they are international athletes, in fact. Would you suggest a word of caution to them on what they could do to probably prevent a cardiac event?
So one thing, remember, there is a hydration schedule for you guys who are heavy exercisers, not the ordinary ones who you just drink enough water, make sure you keep sipping. You see that you never notice a guy who's professional runner without a bottle of water. And most of it not only contains water, it also contains some calories because those sudden flow of calories. And if you're going to be exercising, there is a dietary schedule we are supposed to maintain. You don't take fat because fat is going to take time to start working inside. So you take a light meal, probably about 4 to 6 hours later, 2 hours prior, a little bit of carbs, and then you go ahead with enough hydration during an exercise. And if you're going to do a tremendous or extreme activity, make sure you get your calories in because your hypoglycemia is a big problem. Second is, before you start any of these things, make sure you get a basic cardiac workup done. Look at your family history. One of the biggest markers is a family history of sudden cardiac death. Second is, take a baseline ECG, find out if it's abnormal. There's absolutely nothing wrong. A non-invasive test like an ECG will show you what you have. The second thing is an echo also can be beneficial. Both ECG and echo, there are a lot of things like the athlete's heart that are there, but simple intraventricular conduction delays, your left ventricular hypertrophy, if you have some kind of a heart block or something, and if you have exercised any time and had any exertional symptoms, please don't push. Stop. The problem is people try to ignore. The self-denial is one of the biggest problems. I have had people like, in fact, I had an IPS officer who went on a trip to one of the hills. He went to a hill, like he tried on a trek. He went there, he just collapsed. In fact, his security was there with him, massaged him and revived him. This fellow came back, I did a Holter, he had a complete heart block. So it is not the ventricular tachycardias and faster rhythms. The slower rhythms can also produce cardiac arrest. Now, unfortunately or fortunately, this guy refused a pacemaker because if he gets a pacemaker, his further promotion will be delayed. He had 3 arrests, survived all 3 arrests. I don't know, I lost track of him about 4 years ago, prior to the lockdown, 5 years prior to the lockdown I missed, and I don't have any track of how he is right now. I don't know, maybe he should have retired by now.
He probably has a very long lifeline, a very strong one. At this juncture, I would like to introduce a little drama by bringing in our panelist, Dr. Raj Anand. He's a senior ophthalmologist practicing in New Delhi. And Dr. Raj, I would like you to share your story in your own words and then ask Dr. Prabhakar's opinion on that.
Yeah, thank you, Dr. Arvind. Dr. Prabhakar mentioned correctly. In fact, I started running at the age of 39, formally with a proper training for a marathon. So I followed a particular schedule, which is for 5 kilometer, I trained for 2 months. Then for half marathon, I trained another 4 months. At end of 6 months of proper training, I went for my first half marathon. So it was very nice. I loved it. And naturally, when you love something, you tend to do it more. And I did get my basic heart checkup done. I had no risk factor, non-diabetic, non-hypertensive, non-smoker, otherwise fit. And I was enjoying it. So I never thought I'll have any problem. So after this first half marathon, again, 6 months down the line, in fact, I did my first full marathon also on the Great Wall of China. It is very excruciating, but I did it. So that further boosts your, that you can do anything. And then I decided to go on. This happened when I was 40, 2010. So I continued running, no problems at all. I never had dyspnea, never had chest pain, nothing to suggest that I have a heart problem. In fact, in the similar time when I had my term insurance done, so they got all the stress, echo, ECG, basic, everything was fine. Cardiologist is a friend of mine. I went to him, he did ECG, echo, all good. One critical thing that I ignored, which Dr. Prabhakar mentioned very well, is my family history. My father had a sudden cardiac arrest. He was a known heart patient. He was on treatment, but I never had a heart problem. So I never thought that I will be having. My cholesterol profile was within, say, 100, 150. I thought I'm fine. And when I was running a half marathon in 2012, I was 42 years old. 1 week before, I'd done 21 kilometers, no problem. That day, in fact, I trained well. I thought I'll break all my records, do my personal best. And at 14-kilometer mark, I just collapsed. It was so sudden that I didn't even realize something is coming. I was running with a friend of mine. He told me that we were talking, and suddenly he realized that I'm not there. He turned back and I was gone. So I was extremely lucky that I had 2 of my friends. One of them trained in basic cardiac support system. So he gave me massage. And usually marathon runs don't have so much of facility, but luckily where it was happening in Delhi, they had the whole team of intensive person. So they said that by the time I was taken to their camp, it was a flat ECG. So from that, they revived me with everything, and they transferred me to ICU. I was in coma for 2 days. After that, they did a angio and they found out all three vessels were blocked. LAD was 100%, other 2 were 99, 99%, but I never had any symptoms. So that was a little intriguing. So I asked them, I said, because you are doing marathon, which is a long duration, low impact exercise. So you developed corollaries. So you never had the symptom. But at the same time, plaque was forming, which I did not know. And as I said, none of the tests revealed. Probably angiography would have revealed. But you don't do angiography on an asymptomatic person who doesn't have any problem. So I had a bypass surgery done. Interesting thing, what my surgeon said, it is right you had cardiac arrest while running, but you are alive because you are running. Your heart was strong enough to take the insult. Had you had a sedentary life and had this kind of attack, you would have never made it. So don't stop it. So I continued. In fact, after my bypass, I started doing triathlons, and I did a couple of triathlons. Then presently I'm doing more of yoga, and I do cycling. So I've reduced a little bit of strain. And as you said, 1 hour exercise I think is good enough. So I keep that in mind. I got my CT angio also done 10 years after the bypass because I don't trust any other investigation now. Maybe normal. So CT angio showed everything is fine. So I'm very lucky. I would say surviving a roadside cardiac arrest in anywhere in this world is a miracle.
A couple of points about what you said. You landed up in the hospital. You landed up with a problem. It's not because of that. If you had not done all this, you would have probably landed up in a hospital with a bypass surgery 10 years earlier. That's one point. And second thing is, you have said your LDL is normal. Did you check your LP little a? The lipoprotein A is a very ignored factor in India. What is your lipoprotein little a? Because this is a genetic marker. What happens is people look at LDL cholesterol, apolipoprotein B, which is the ultimate goal of treatment. LP little a is something that is very high among Asians, and it is supposed to be not the good or the bad cholesterol. It is supposed to be the deadly cholesterol. LP little a produces more inflammation. It is 6 times more atherogenic than LDL cholesterol. But LDL is given more importance because by sheer numbers, LDL is more. But this is a smaller one, but more dangerous. You probably should look at LP little a. And if your LP little a is high, there are no specific treatments available for LP little a lowering today. But there is this newer PCSK9 inhibitors, we can bring it down by 25%. There is new olpasiran that is coming up, which is actually meant to increase HDL cholesterol. That brings down the LP little a by about 50%. Then you have the newer drugs like pelacarsen, which are coming up. This is going to come up in 2 years from now. Once that comes in, there are a lot of patients who I know have very high LP little a. You can't do anything much about it. None of the conventional therapies. In fact, the statins that we give can actually increase your LP little a by about 7%. So please check your LP little a. Probably that is the missing factor in your story. I think you should be searching.
I'll do that.
Thank you, Dr. Raj, for actually bringing that. Now it's almost 14 years since the event, and you're still going strong. Sometimes, I always like to say we all have two lives, and you realize your second life starts when you realize that you always had only one.
Your second life starts when you have your girlfriend, yeah?
That can be the other way around also.
That can be, sometimes can be good, sometimes can be miserable also.
Bad.
In fact, the discussion on cholesterol, I always find it a very interesting topic. But for want of getting too deep into one topic, I'm going to stick to just asking you, sir, about screening in India. There are no labs which screen specifically for ApoB and Apo small a very reliably. This is my understanding. You can correct me if I'm wrong. But what would you suggest? Would you suggest that also as a screening tool?
This is a close meeting among doctors. I'll take the liberty of calling names and calling labs.
Yes.
So the biggest problem in assessment of cholesterol is the way cholesterol is measured. Most of the big labs in Chennai actually do not measure LDL cholesterol. They calculate LDL. If you remember your biochemistry, the Friedewald equation. Now, I have published a paper on this stating that 40% lowering of lower levels of LDL cholesterol are mentioned when you do the Friedewald equation. It's one of the biggest, it's published in an index journal. So you have to look at the lab which does a direct LDL cholesterol. ApoB is done in most of the labs. It's reasonably standardized. LPA is a problem because most of them do what is called as immunoturbidometry, which is measuring in milligrams. The actual method to do it is in nanomoles by spectrometry. It is actually very difficult. So it is not done by any of the labs in Chennai. In fact, I had a tough time trying to get it done, but it was not possible at all in any of the labs. But in milligrams, if your LP little a is more than 50, it's bad. Now, I'll give you a few simple numbers to remember for all the people who are listening here. The LDL cholesterol, nobody can have an LDL cholesterol even in primary prevention of more than 100 milligrams per deciliter. This is for India. If you're a diabetic, you don't have an LDL that is more than 70 milligrams per deciliter. If you're having a heart disease, get it down to 50. Now, if you have had a bypass and a stenting or recurrent heart disease, or a polyvascular disease, like let's say you have had a stroke, then you've had a heart problem, bring it down to 30 milligrams per deciliter. Now, this reference range that I'm giving you, 100, 70, 50, and 30, is not given by any of the labs. All labs tell you the optimal value is 100. All doctors, including ophthalmologists, are very happy with 100. And even if a patient comes to you stating that he's got an LDL of, let's say, 25 or 30, they tell you, no, your doctor is giving you very high dose of medicines and reduced medicines. Now, remember, cholesterol is something, not lower the better, lowest is best. Not lower, lowest is best. So how safe is low levels? There is data to prove that LDL cholesterol in single digit is safe and effective. So don't worry about your LDL cholesterol. Bring it down as low as possible. Keep it down. Should you be on a statin? Try lifestyle modification. Most of the time it works. I will tell you my own HDL cholesterol. My HDL cholesterol in 2006, when I checked for the first time, was about 34 or 35. So once I started walking, exercising, doing all kinds of things, though I'm looking a little heavy at this point of time, thanks to Nirmal and all his meetings that he's been having. So despite that, now my HDL cholesterol is about 50, just with good physical activity, nothing else. So you can do a lot of things with lifestyle modification. And I think it's something that all of you should learn and start doing it on your own. I think we'll close the cholesterol story here. There are several other things to
Yes,
talk.
I know it's a big Pandora's box, so I'm going to steer away from it. And
Arvind, one point.
yes,
One point. Sorry to interrupt. So
please.
he was mentioning about the statin intolerance, because having taking statins, I find it very difficult because you have to bring down the LDL. See, what my cardiologist said is you have to take at least 20 of atorva. But even 10, I can't tolerate. It causes severe myalgia and what you say, the tiredness. I find it very difficult. And we say post any cardiac problem or to be healthy and fit, you need to spend 1 hour a day with your body so that 23 hours the body takes care of you. With this 10 or 20 milligram, I find it extremely difficult.
Dr. Kasi, that's a wonderful point. Now, the point is statin intolerance is mostly driven by the internet and not by the patient. Let's face the
No, this
truth.
is physically, as a
Let
patient.
me tell you, I understand your problem. Let me give you an answer to that. So what happens is the actual statin-induced muscle side effects and intolerance is about 5 to 7%. And when you start having muscle symptoms, it is usually within the first 3 months. What happens after 3 months is not statin associated. I have had so many orthopedicians tell you, you have this joint pain, you have this muscle pain, it is all related to statin. Ask your doctor to reduce to statins. It is 100% not related to statins. I mean, even if you have your CK levels, creatinine kinase levels assessed, up to 4 times upper limit of normal, you can still be all right. Now you are symptomatic with even 10, 20 milligrams of atorvastatin. Okay. Now, if you don't tolerate atorvastatin, change over to another statin like rosuvastatin. If you can't tolerate, the best resort for those people is not these two. There is something called a plant-based statin called a pitavastatin. You try pitavastatin. Now there are alternative to statins like ezetimibe, and there is bempedoic acid also available. And
Bempedoic acid. I tried bempedoic, and typically the graph says it can have back pain and then bloating. So I typically had the same thing.
So if nothing works, your last resort is to go for a typical statin intolerance, inclisiran injections.
Inclisiran.
Once in 6 months, you take these injections. I have about 30, 40 patients on this with about 40 to 50% lowering of LDL cholesterol. If you are into secondary prevention, don't try all this. Straight away go for that. And now it is available. It was launched at 1.2 lakhs per dose every 6 months. Now it is available at buy one, take one free for the entire India. And it is available for 85,000 rupees. And there are some companies which give you the statin free or any of their drug companies medicines free because it's promoted so much.
So for your information, sir, with this February end, that 1:1 offer is getting over. 1+1 offer is over.
I'm an advisor for Novartis. It's not closing. Don't worry.
Okay.
I'm an advisor for
Since you
Novartis.
brought up atorvastatin,
Kasi.
we have an audience question from Dr. Vijay Raghavan, sir. He wants to know if atorvastatin can cause insomnia.
Sir, it is actually not listed in their side effects, sir, but it has come up occasionally with patients. I have noticed this. So I just don't do anything much. I just give them melatonin, which is a very simple thing to do. And most of the time you tell them that you take melatonin, this will disappear, it goes away. The second thing also about statin intolerance and these side effects is if you supplement vitamin D, sometimes these symptoms do come back because vitamin D deficiency can also worsen statin-related effects. Two other points about statin intolerance, which Dr. Kasi was telling. One is look for hypothyroidism. And second, if you're on a calcium channel blocker, it can aggravate the muscle side effects of this thing. It's very not well known. But typically, calcium channel blockers can worsen your statin-associated muscle side effect. There are lesser known facts, but if you still have a doubt, you can do one thing: go on the internet, search for myths and facts of statins, and put my name, Prabhakar. I have written a paper in Journal of Indian College of Cardiology, which is actually one of their most read papers in Journal of Indian College of Cardiology. You might be, since as doctors, I think you can easily go through it. It addresses all the side effects of statins.
Kasi, I have
Yes.
been taking Ataro 40 for so many years. Prabhakar is aware.
Uh,
One thing I do is I'm taking a lot of medicines. I never go to the net and find out what are the complications, what are the possible things. If
no,
anything
I
comes, I'll put the blame on Prabhakar.
I never looked, I experienced all those things.
Now, let
As
me
a
tell you,
doctor, we are the poor patients. We don't look into
no,
the side effects before taking medicines. But once
Kasi,
we take the medicines, yes, sir.
I'll also add one more thing. I have now the recent trend is to give upfront combination therapy in secondary prevention. We give 40 rosuvastatin, bempedoic acid, and estimab all together. And even then, you achieve a goal LDL of 50 milligrams in only 70% of patients.
I'm planning to switch over to inclisiran. Just want to try inclisiran.
Sir, absolutely fine. You have anything on inclisiran, tell me. I can help Novartis to get you whatever you want.
No, I'm also a Novartis user, sir. We have a lot of anti-VEGF injections.
Dr. Kasi is not going to rest till he finds
Hmm.
statin which doesn't give
It's a
him
wonderful drug.
pain.
No, it's a wonderful drug. Inclisiran doesn't have any side effect apart from the local injection site problem. It's a wonderful drug.
Okay.
Dr. Kasi, since you have taken the batting side, why don't you share your story also?
Okay. So I would say I don't have any comorbid conditions like diabetes or hypertension, and not obese as well. So I used to play during the COVID times. I started regular working exercises, badminton and all. In fact, on 23rd December, I would say 23rd of 2023 of December, 4th. That's the time I used to play badminton 5 days a week. So 2 days I take a break, and the day it's Sunday. It was a Sunday. I was playing badminton for 2 hours, no problem at all. Everything was fine. The next day, Monday, early morning, 4 o'clock, I had the pain. It was typically, as explained in Harrison, an elephant sitting on your chest, some compressing pain on the chest. Then I thought it could be maybe of acidity or something like that. I had a glass of milk from the fridge, but didn't get away. And then I was a little sweating. I thought, why this unusual thing happening early morning, 4 o'clock? Then I thought, okay, let me check the blood pressure. I'm not a hypertensive also. When I checked the blood pressure, it was around 150, 100. Then I realized something is happening. And slowly the typical symptoms started radiating to the jaw. Then I realized, okay, this is not something which simple to think. And by the time my wife woke up, and the irony was, 2 weeks before this incident, I was in Russia for a meeting. So it's cold sub-zero temperatures. And I don't know whether it's coincidental or anything related to this. It's cold temperatures. I was there for a week. And when I was in Russia, my father had a sudden a blackout, and he had a LAD 100%, and he was admitted, and then he was suggested bypass, CABG, when I was in Russia. But the cardiologist told me, no, that's fine. My father insisted that I have to come back for the surgery. So 1 week he was hospitalized. And then when I came back, and this 1 or 2 days later, I had this episode. So I just, morning 4 o'clock, it was 4 o'clock. Then myself, my wife, and my son, and I took the car myself because that was a flooded day. December 5th was, I can't forget that day. It was heavy rains and Chennai was flooded. So since I know the routes, I don't want to get caught in the traffic. So I took the car myself, my wife and my son sitting beside me, then drove the car and then went to Kaveri because my father was admitted in Kaveri. And my father was supposed to get discharged on Monday. And then I got early morning, 5 o'clock, admitted into Kaveri. And that day it was flooded roads. They couldn't get the doctor online because mobile phones were out. So, but luckily they sent the ambulance and then got the cardiologist and then had an angiogram immediately. So angiogram, they found one block, right coronary. So it was 95% block and immediately was stented and I was absolutely fine. And the moment the stent was put and the plasty was done, you felt the sudden relief from the chest. So that's how. But one thing which I would think when I was listening to all these things is there is a strong family history because in our family at 50 and one person at 45, at least 6 people had MIs and one person passed away at 52, and rest all are surviving. One had CABG, that's my father. Other had stent. So 6 people had MIs. And one thing which again I would think is all this, most of except me or two, all four are strict vegetarians, absolute teetotalers. So this is maybe a genetic history, that family history, as Dr. Prabhakar was telling. Since all of us in 50s we had this, there is a strong family history or something like that. That's what I would correlate it. But only thing is identifying thing and immediately attending to that made me to survive the episode despite the floody December 5th.
Two points in that. One, you are not sensible enough to drive the car. You never do that. You don't do
but but the
No,
December 5th we
it is-
didn't have a
No,
choice
I
because
understand.
of.
I understand that. But I think you should start training your wife and your son to drive the car, which is going to be very sensible.
No, I was not confident with their driving, so I want to survive.
No, and
If
in
we-
fact, I actually those are very relevant things. So I would like to ask Dr. Prabhakar at this juncture, mentally, how do you prepare your family, which is your first responder, when you have the earliest symptoms of a cardiac event? What should you tell your wife, your children? Because this is across ages and it could happen to any of us at any point of time.
Time is muscle, time is essence. 50% of the mortality in myocardial infarction happens before you reach the hospital. Most of the deaths are because you don't reach the hospital on time. So what you need to do is make sure if you suspect something, you don't lose anything by just going to an emergency and taking an ECG and probably a troponin. Now we have highly sensitive troponin, which picks up within about 3 hours. 2 to 3 hours. And even if you're going less than 3 hours, 0 and 1 hour protocol will effectively, which most of the hospitals don't understand, that's a different story. But if you do that, you're able to get a negative result. You can rule out myocardial infarction pretty fast. If you are in doubt, just go to the hospital, take an ECG, nothing wrong. And at least do it. Now every hospital has got an instant kit of HS troponin, which is they'll tell you nothing to worry. How to prepare your family? Very simple. Make sure there is somebody else driving the car. It's not very sensible. Like the problem is in myocardial infarction, people don't die of the cardiac failure. They die of ventricular tachycardia because the myocardium is irritable. And if you have a ventricular tachycardia, what do you do? Simple. The only way to maintain the circulation would be to probably cough. When you cough, you increase intrathoracic pressure, raise the blood supply to the brain. So there is something that you can do yourself, but it's not going to be 100% effective. It just buys you time till you reach the hospital. That's all you can do. Other than that, I don't think it's going to be very effective. But I think the way to prepare your family is make sure that everybody learns a little bit of driving, at least in an emergency to take you somewhere and save you. You are lucky.
How about taking an aspirin or a sorbitrate at that time? So some of these we
Now the point is there are two things you must understand. Aspirin, nothing wrong, but if it is an acute gastritis or if you have something that is going to be like a dissection of aorta, if you have not recognized it properly, if you're taking aspirin, you're going to kill yourself. And these people keep saying, keep an aspirin, take it. Now, I have seen patients die because they've taken aspirin. Second thing is nitrates. Like if you have a heart problem, take a nitrate, it's fine. But there is one important subset of patients, inferior valve myocardial infarction, like what Dr. Kasi had. He had a right coronary artery. If he had a right coronary artery that is very proximal with the right ventricular myocardial infarction, if he had taken a sorbitrate, he would have had a profound venodilatation and collapsed. This is something that you must be aware of. So if you're in the low normal blood pressure, don't try to do it. And when you take the sorbitrate also, don't take it down lying, don't take it down standing. You have to take it down sitting, back supported, and make sure that you're resting. And don't try to get up. I've had one patient of mine who was regularly working, and this fellow had chest pain. He had a sorbitrate. He went at 8 o'clock. He had his full meal. He was climbing the staircase in Egmore railway station, and he climbed with his box. All that you should not do. Don't go walk after a heavy meal. Don't climb stairs and don't carry a weight and walk. He did everything, developed chest pain, took a sorbitrate while walking because he was late for the train and dropped down with hypotension. Next, he was there in GH. So these are things that you can't do and you have to be careful about.
As you said, the basic BLS, I think should be. I think now the schools are also started teaching the basic BLS. BLS comes in hand.
I'll agree with you. We have had some camps on basic life support. In fact, like I said, ACERT, we have this group that with which we did a camp last year for in about 5-6 locations in camps among people who were walking. And we did a BLS. We had an instructor. We had mannequins, 3 mannequins per station, and taught people how to do a BLS. So I think it is there, but very tough ask. Very tough ask.
I have a point here, Prabhu.
Yeah, go ahead.
Non-medical people doing BLS is excellent, provided they identify it's a stopped heart. On a beating heart, they shouldn't get up and start pressing the beating heart also, which I have seen. So that is only thing. But BLS is excellent, especially in a doctor's family. But they don't get hands-on. I mean, I know Prabhakar is aware. Saved one of my own relatives in the middle of the night. Be shifted within 15 to 20 minutes. In the hospital, had a VF, and defib was done, and then next day surgery was done, and he survived that for 10 years. But it is really helpful identifying, and that time we called an ambulance. I don't take a risk. Prabhakar is aware of it. Yeah.
On the lighter side, we always used to say, I'm sure Nirmal is aware, like if the girl is pretty, you can do it. You don't have to bother about the pulse, do a CPR. So that we keep telling that. I'm sure Nirmal is aware of this joke that we used to have. But basically, when you do a BLS, they first teach you to look at the carotid pulse. Without that, and they always say tap the face and make sure he is awake. If you are able to awaken the patient, don't do a CPR. Don't start a CPR without anything. You just may have to make sure the simple things, and the massage only CPR works. There's no question of this mouth to mouth respiration. That's all gone. Nobody talks about that anymore when you do a BLS.
Compression only CPR, no.
Compression only CPR. I think you are the boss. You have done a video on that, which you can share later.
Correct.
Thank you,
At
sir.
present, we are also doing some programs called Jeevan, which is a BLS training program conducted by IMA through all its branches in schools and colleges. So it has reached 4 to 5 lakhs in the last 6 months. So it's been a good program. And yes, it is an updated version. And only thing the learners have to be is follow the step-by-step protocol and don't mix it. It's very, very important. Like Prabhu said about checking the carotids. And so otherwise what happens in breathing hearts, they keep doing compression. And so these are things that to be avoided.
So from
And one more risk area is the batchmates, right? We used to have a ALS supported ambulance in all our batchmates, right?
Yeah,
So,
for all the dance that we all do,
yes,
and go until late in the night.
I think we should
Nirmal is
recommend
very
for all the
particular.
DJ programs also.
We have it for our batchmates and also for TNOA. We keep a ACLS. This time, as there are some ideas, we will do a cardiac screening in our TNOA.
So from some morbid topics, we'll shift a few more interesting lifestyle ones. So in terms of diet, the most favorite topic, and I'm sure you counsel a lot of people, what is an ideal diet that you would recommend for a healthy heart?
So the biggest thing, let's go back to cholesterol. Whenever you tell a patient he's got a cholesterol, he always ends up telling you that I will manage with diet and exercise. Now, first thing that all of you should understand is only 20% of your cholesterol is from your diet and your exercise. All these things are going to happen. 25%. Rest is all synthesized by the body. So diet today has a reasonable amount of value, but beyond that, it's become it's actually not much of an entity today. This is the truth. It's not going. People don't accept all these things. Lot of places they will tell you all kinds of stories about it. So, but still, what is healthy diet? Very simple. The DASH diet, basically have plenty of fruits and vegetables and avoid increase fiber, reduce the fat, increase the monounsaturated and polyunsaturated fats, and avoid the oil, fat, butter, ghee, avoid red meat. It's the whole list of things. I'm sure all of you can go on the net and pick up all these things. But if you want a healthy dietary advice, two things will stand out. One is what oil you take. That is something that crops up everywhere. Now, the healthiest oil is going to be a mix of most of the oils. It is not going to be a single oil. Now, each oil has got polyunsaturated fatty acids, monounsaturated fatty acids. So the best oil is going to be have a little bit of probably gingerly oil or something for your dosa. And when you cook, start using the sunflower oil, which contains more of polyunsaturated fatty acids. The gingerly oil contains more of the monounsaturated and polyunsaturated. The monounsaturated is also there in mustard oil. You'll be surprised to know that we did a lot of research through Lipid Association of India and found out that mustard oil is actually one of the very good oils for India. So that is also there. So you can mix the oils, take a little bit of each oil, don't take plenty of them, little bit of each. Each one has got poly, mono, and all kind of oils, and have a little bit of each of those. In principle, don't overdo your eating. Don't do this hedonic eating where you eat without what is more than what is required. That is one of the biggest causes, that because the problems that we have. I'm sure none of us can control if you have a good ice cream or a good gulab jamun or whatever you like, your sweets that you like and whatever. It's all difficult, but that you have to overcome. Remember one thing: if you eat all those things, burn it out. You have to probably run like Arvind or Nirmal and try to burn out all that you have eaten. It's a tough, tall order, but it's going to be difficult. Overall principle of diet, have a principle of a diet. Have plenty of fruits, plenty of vegetables. Instead of juices, fruits and vegetables are better. Avoid too much of caffeine. To some extent, caffeine has been proven to be beneficial. To some, caffeine is beneficial. And beyond that, I think it should be more of a healthy diet. The newer things, like if you're a diabetic, have plenty of these millets that you have. These Kudravali, Kollu Sama and all those things. They are all beneficial. Add up. Instead of having idli dosa, mix these things up. Generally, in principle, what you do is 50% is going to be vegetables, 25% is going to be your rice or idli or dosa, 25% is going to be the protein of sambar or dal. So this is the principle of eating. If you maintain it every meal, and now you're going to ask me, how am I going to maintain it during breakfast? One is add the millets, and two, have a sambar with plenty of vegetables, and have the vegetables. I think this is the simplest explanation for diet I can give you.
Thank you. And in fact, that's very pertinent that you shifted the focus on to vegetables rather than rice or carbs, which are the predominant South Indian meal.
So the
Sure.
vegetables also, in simple, the basic thing you say is, all that is above the ground, take in plenty, all that is below the ground, reduce it. That kind of oversimplifies the diet.
And in terms of sleep is probably the most underrated. But what would you say about sleep deprivation, especially people working extensive hours, students, fellows working 36, 48-hour duties and not sleeping enough? What is the role of sleep in cardiac
At an
illness?
early stage, yes. But beyond a point, I think you should all understand. I think all of you are consultants and all of you are doctors here. I think one thing all of you should understand: if you don't sleep for 7 hours, you're going to get dementia. Before we used to say 6 to 8 hours, now 7 hours. Chandrasekhar, remember 7 hours of sleep. If you don't sleep 7 hours, you're going to get dementia very fast. So make sure all of you sleep for 7 hours. Because this is now proven in large scale studies that 7 hours of sleep is mandatory now. The 6 to 8 hours is gone, and make sure that you're going to sleep adequately to get enough sleep. That is mandatory. In fact, I will give you one point saying that the WHO and everybody has come up with what is called as life's essential 8. The big 4, the smoking, diabetes, hypertension, and cholesterol is 1-4. The other 4 are the smaller 4, which is going to be your diet, your physical activity, your weight, your obesity, and 4 is sleep. So sleep has gained so much of importance. And I thought I will just add a few points which I have not touched on. One is going to be, you don't look at body mass index or weight. Nowadays, what we talk about is a very simple parameter called a waist to height ratio. It doesn't have to be standardized for anybody. You have your waist circumference, which is your maximum waist circumference, and then look at your height. If it is more than 0.5, you're overweight. Now, this seems to be the best parameter today. That most of the definitions still talk about body mass index. So look at your waist height ratio. If it is more than 0.5, it's time for you to lose weight. Go on a diet, exercise, and all these diets and exercises, everything. Like people talk about intermittent fasting, this, that, everything is there. There are a lot of things. But ultimately, goal is, it is a negative balance between what you eat and what you burn. And most of these intermittent fastings work only because your caloric intake is less. That's the moral of the story. Arvind, you have not touched on a few things. We don't have much time. I'll just give a few points which I want to add up. Because one thing that all of you can understand is hypertension. The most neglected disease is hypertension. Cholesterol, yes, a lot of talk, a lot of say about it. Hypertension is something neglected. Hypertension, the risk actually starts from 90 millimeters of mercury. From 90 plus, there is an increasing risk towards stroke and heart disease. And if it is beyond 140, it dramatically increases. So beyond 140, you need to be treated. And any comorbidity, like if you're a smoker, diabetic or anything, you can't have a systolic BP more than 130. And the abysmally sad part is that the control of blood pressure is just 10% in India. That is something that is worst. in India. And we have to strive towards improving. There are several patients which I've got from ophthalmologists saying he's got a hypertensive retinopathy. Check his BP and start treating him. It's as bad in India. So that's one thing that you have to treat, and make sure you get to a target systolic blood pressure of 120 to 129 today. Your goal
120
LDL
to
for primary
129.
prevention is going to be 100, because the 120 to 129 gives you a range. Before we used to say 140, 130. No, 120 to 120. If you get it less than 120, again, there is a J curve. So don't bring it down too low also with medication. But if your natural BP is 110, please don't bring it up. Leave it. Don't worry too much about it. So be very clear about what you're doing. And prevention is something that is the most neglected aspect in heart disease. Keeping an eye on the heart, basically what I wanted to say was, look at all the risk factors. Don't look at just one risk factor. It's not just cholesterol. And like Dr. Raj and Dr. Kasi, who have had problems at a very young age, I think they're still not in. When I spoke about LP(a), Dr. Raj was quite perplexed, and he was literally trying to ask me what is LP(a). So that is the status of preventive cardiology among cardiologists. Sad part. That's how it is. And my biggest problem is whenever I talk on inclisiran, which Dr. Kasi wanted to start on, I'm one of the biggest speakers for inclisiran for Novartis. And when I talk about inclisiran, I talk about my own experience and how I treat my patients. The biggest problem is people are not bold enough to start this. He should have probably been started on day one when he had the statin intolerance. Please don't delay. And earlier the better, lower the better, longer the better. And today we say lowest is best for most of the risk factors.
So just one word on HbA1c also. I guess we discussed that, but could you add what is the HbA1c we should start pressing the alarm button on?
So when does HbA1c start creating a problem? What do you think is the HbA1c when the problem starts?
About 6.4.
Yeah, that's what you think. From 5.5, the risk starts going up. So compared to a diabetic who is having HbA1c of 6.5, it's a diagnostic. A pre-diabetes has more compared to somebody less than 5.5. 5.7 is normal. 5.5 to pre-diabetic range up to 6.4 is a slight increase in coronary artery disease. But beyond 6.5, it increases. So it is not that pre-diabetes is safe. Diabetes has got the worst, pre-diabetes is bad, and normal up to from 5.5, the risk starts going up. See, these numbers are all arbitrary. We have diagnosed those numbers. We have fixed those numbers. They're not real absolute numbers. And when you are on a diabetes, you are getting treated, keep your HbA1c 6.5 to 7. Less than 6.5 is beneficial, but there is a profound risk of hypoglycemia. And hypoglycemia, mind you, has got a big problem. If you get a hypoglycemia, within the next 48 hours, the body reacts in such a way, there is a higher incidence of cardiac arrest. So to avoid that, we keep telling 6.5 to 7 is a safer value. And for older patients, it is better to have a higher HbA1c. Don't go for low sugars. Slightly higher sugars are reasonably safe. And nowadays, diabetes has got excellent medicines. The SGLT2 inhibitors, which have come in of late, they are the first drugs which showed that you can reduce cardiovascular mortality. So you have wonderful drugs today. You can start treating them adequately.
Just one question. Audience, what is your view about coconut oil? Favorite question every time, sir.
Yeah, so there are two things about coconut oil. Coconut oil is full of saturated fat. Now, I said the fat is not really there. Now, the saturated fat story about coconut oil is very, very interesting. If you start taking coconut oil and these saturated fats early in life, it has actually been shown to be okay. But once you start getting a coronary artery disease and a problem, the saturated fat is not so supposed to be good. So it's a very, very ambiguous situation. You really can't talk much about it. Maybe you can add one pinch of coconut oil because if you like it, you can start taking it. But better thing is to apply it to your head.
Point taken, sir. Has COVID increased sudden cardiac death in younger age?
Yeah, there has been a significant increase in COVID and COVID-related problems. We have noticed it, and the data has shown slight increase, but may not be really statistically significant. But a lot of things are really very murky there because the data has not really been shown. If you look at the data on the COVID vaccination, you will see that Astra totally blanked their entire side effects data. So a lot of things about COVID are not sure, but now that we are behind it, I think let's all go forward and try to look at what we can do. I think we should do what we know we can do. And that's important. I think what we can change, we already said life's beautiful 8, and we can control several risk factors. Let's control them, and rather than not to try to think about what COVID did, because practically everybody developed COVID during the second wave. and everybody developed it subsequently. And even now, COVID is still there. We are still seeing patients with COVID, but it's much less virulent and it is not being that dangerous. But let's start looking at what we can do and start talking about positives rather than going after the negatives. And that could have been there. It could even now patients keep telling me I had COVID in 1944 and all those nonsense that they keep telling. Just ditch all those things. I think let's go forward and start treating ourselves.
Absolutely, sir. Thank you so much. If anybody else has any questions, the panelists, Dr. Chandrasekhar, Nirmal sir,
Now, what would you say? What would you suggest? Like for the 50 plus or 45 plus, would you say wouldn't have any cardiac event, or if they had a cardiac event for the follow up, would you suggest a CT angio or a treadmill, or when
Sir,
it has to be done? What's the gap between them to be done?
Great, Dr. Kasi. I think this is something that is the burning question in cardiology. So what we tell you is, by trying to do a CT or an angiogram, or even if you find an 80%, 90% block on your RCA, by doing an angioplasty, you are not going to prevent a myocardial infarction. Mind you, I'm very clear about this. You don't prevent a myocardial infarction. So the plaque is unstable and it produces myocardial infarction. So the core of the lipid is exposed and produces myocardial, which is what happened in your case. You probably had an unstable plaque which created a problem. So if you treat all the risk factors correctly, all right, around 40, 50, you can do a calcium score to assess what is your calcium score. If your calcium score is 0, the chance of a disease at that age is very good. By doing a calcium score in somebody who is 30 and 40, he's not going to develop calcium. He still might have a significant plaque burden. So somebody who's got a chest pain doing a calcium score, it doesn't work in 30s and 40s. But if you do a calcium score in 50s, there it shows there is a marker for a disease. Now, if somebody has a calcium of more than 0, it is a marker for disease. Put them on full prevention. I will bring their LDL, the cholesterol down to 50. That will not only reduce the cholesterol, and a cholesterol of LDL less than 50 not only stabilizes the plaque, it also reverses atherosclerosis. We have seen reversal angiographically and intravascular ultrasound. So what I will suggest is don't go for a CT angiogram. You will end up getting an angioplasty or a surgery. Because once you see 80% lesion, you will be so panicky, you will go to the cardiologist. I've had this happen. Typical example is one of my father's colleagues, who Chandrasekhar knows, who was a former DGP who actually died in Coimbatore ultimately. And this gentleman had a CT angiogram because somebody offered a CT angiogram during the World Heart Day. He underwent a CT which showed double vessel disease. Then he went and underwent a bypass surgery. So, but whether it was required is a big question. Like, what have you tried to prevent? You have undergone a bypass surgery. He might have been all right even without the bypass surgery, with good cholesterol lowering and good medication, and probably an aspirin. But when do you need aspirin? That's another small point about it. Two reasons. One is if your calcium score is more than 100, or if you have at least a 50% lesion on a CT or a conventional angiogram. Otherwise, there is no role for aspirin or clopidogrel in primary prevention today.
And how about treadmill? When would you say? Do you think that's a good marker every year they can do after 50 years or 45 years?
Treadmill is not recommended at all nowadays. Treadmill is not part of the risk factor stratification. Treadmill is not going to be beneficial at all. If you have symptoms and if it is very typical, go ahead and do a CT angiogram or a conventional angiogram. If you don't have any symptoms, why do you want to put him on a treadmill and do one thing? Control his risk factors. Get his risk factors down considerably. But for somebody who's going to run a marathon, I'll put him on a treadmill to make sure that he's going to be fit enough to exert himself to a very large extent. There it is beneficial. But otherwise, treadmill nowadays, we don't talk much about it. And in the risk factor stratification, treadmill is not going to be there. And in fact, in diabetic patients where they routinely do a treadmill, there has been one trial called the DIET trial, which has shown whether you do a treadmill or not, whether you treat them or not, just medical management, treadmill can become from positive to negative. So routine treadmill is not recommended. I know I'm going to be very drastic in telling you this, but that is the truth. No cardiologist is going to tell you this.
That's what I'm a bit shocked.
No, it is actually, I think it's inappropriate to ask question like which test to be done, which should not be done. I think it's up to the cardiologist. And like we, most of the time, as ophthalmologists also, we would be the best person to suggest what would be appropriate for that patient for that situation, rather than generalize that a test should be done for everybody. I think that is one take home that Dr. Prabhakar has said. Look at all the risk factors, actually look at cholesterol and blood levels of the specific biomarkers and treat them specifically based on those things. I think there's a lot of impetus on controlling hypertension, cholesterol levels, watching HbA1c, living a healthy life rather than jumping on what is the next possible modern test to probably predict a cardiac event. And I think none of these tests have actually predicted an event very correctly in any of our panelists' case. Am I right, sir?
I think to both of you, I think your family histories have been very strongly positive, which I think both of you have ignored. And LP little a is something that is very ignored. If you have not done, please check one. So this is not to all of you who are listening to this whatever poem Zoom meeting.
I actually read about LPA, I think 4 years ago when I read Peter Attia's book on Outlive. So he mentions about LP small a, but I couldn't get any lab to do it at that point of time. Even ApoB was unheard of. And like you said, the metric values were not standardized. But hopefully now, the current medical scenario, those things will become more relevant and be better biomarkers.
It is available now. It's available in most of the labs. Less than 30 milligrams of LPA is okay. If it's more than 50, it's high risk.
30 to 50.
Prabhakar, I have a question.
Yeah, sure.
Apart from sleep, we ophthalmologists are one of the highly sedentary professionals. We sit and see patients. We operate the patients also in the sitting position using the microscope and all devices at all odd angles. So how do we manage this sedentary situation to improve the heart function?
Sitting is the new smoking. I'm sure all of you have heard this. Sitting is the new smoking, which we say. But there is a very clear paper in JACC, which came about 7 years ago, which has said you can overcome the sitting for 4 to 8 hours by just 150 minutes of exercise every day. That's all. And the second thing, more recent thing that which I have been noticing people do and people keep talking about is all these simple Tai Chi exercises where you just try to stretch your arms and do your flex and flexion exercises. You can do it every hour for about 2 to 3 minutes. It just overcomes the problem of your of sitting for prolonged periods of time. So between patients, you do. In fact, in the last 1 month, you will be surprised to notice that I've also started doing this. If a patient goes out, I just keep junking. My son keeps coming and said, "Hey, Daddy, what are you doing?" So this happens. So it doesn't matter really. I think you can start doing your own exercises. And the other interesting thing that happens is your step count. Anything beyond 2,500, going up to 10,000 is beneficial. So keep a step count. You have a Fitbit watch or your mobile phone with your count. That is very, very useful, especially for older people, because it quantifies the amount of work that you do. And by 4, 5 o'clock, you realize you walk less. You tend to walk more. That quantification is something that is really useful. It's a big motivator.
The step count challenges have always been a motivating factor. And you also see the person next to your screen. I can see Dr. ERB, who clocked 2 lakhs plus step count in 25 odd days.
But unfortunately, had a problem of right coordinate occlusion as well as other thing also.
That was a surprising factor. So I thought, sir,
I had undergone CAPG. I had undergone CAPG.
Yeah, Prabhu knows about it.
Sir, like I said, you don't prevent. You do what is to be done, and you can't control a plaque from becoming unstable. That is something. And another important thing about exercise: please warm up. No warm up, no exercise. That is very, very one of the main reasons why they clock and create this problem. I had a pediatric colleague of mine who, at 35 years of age, developed a myocardial infarction. What he did, he got one bag full of 2, 3 bottles and some bananas for his friend. Went to the Egmore railway station to drop him. Train was started moving, so he ran down the platform to go and give it to the fellow. Landed up with chest pain. Came with an acute anteroral myocardial infarction at 35 years of age. So these things do happen. So he did not warm up. Sudden spurts of activity that I think all of us should recognize that it can happen to anybody at any time. So don't do this activity. This advertisement about having my Kellogg's for breakfast and muesli for breakfast is only on the movies and in the advertisements. Real life, please don't try all those things.
Prabhu, you have spoken about aspirin and clopidogrel. We see many of these patients coming. This is out of portion. Where do you advise them to stop? Aspirin is okay. Should you stop clopidogrel for a surgery? Cataract surgery or an orbit or a retina surgery? Make it a very short answer.
So currently we say your ophthalmic surgery, basically the cataract is in bloodless surgery, so you don't have to stop these antiplatelet agents. And all the guidelines have clearly understood it's only the ophthalmologists who are old timers who don't do it. All the youngsters who I see of late have started operating on the antiplatelet agents. And beyond 1 year, if your patient is on dual antiplatelet, which is aspirin and clopidogrel, I think it's a mistake. Now we have shortened the duration of antiplatelet therapy beyond 1 year. Most of the patients don't get a dual antiplatelet therapy. Most of them get a single antiplatelet therapy. With the single antiplatelet therapy, you can reasonably safely do surgery. In fact, most of the surgeries can be done. In fact, bypass surgery is done on a single antiplatelet with aspirin alone. And more recently, if you're on a secondary prevention, these are a couple of people who have had bypass surgeries and angioplasties. We say that clopidogrel is superior to aspirin in terms of long-term treatment, provided you don't have a clopidogrel resistance. That's a very point to argue.
Thank you.
There's something called clopidogrel resistance. How do you know that?
So there is in vivo, in vitro resistance. What I do is I do a genetic study which costs about 1,200 rupees in a genetic study. That will tell you whether you are a hyper responder, non-responder, or an intermediate responder. It just costs about 1,200 rupees. They do a buccal swab and give you the result in about
Dr. Kasi, Dr. Prabhakar is going to send you a consultation fee bill tomorrow.
I'll do a free eye checkup for him. It's mutual.
That's good.
That is not
I
going
have,
to
I have
sell
so
it.
many ophthalmologists on board. My sister is an ophthalmologist, brother is an ophthalmologist, Nirma is an ophthalmologist.
And he's a
But
very close friend of Chandran Abraham and Mary Abraham.
but I'm a retina specialist as well, sir. I can
Ah,
check the retina better than all of you.
Srinivas Rao is my very close friend.
So they're all anterior segment. I'm a posterior segment person, so I can do a better job on the
Because
retina.
Chandran Abraham was a retinal surgeon. Hello.
mm,
Yes.
Chandran Abraham was a retinal surgeon in
Yes, sir. Yes,
Shagametala.
sir.
Sir, he is
Kasi,
very close.
once in lifetime, you have to pay your doctor, Kasi.
Yeah. No, we doctors, we don't collect fees from the doctors, right? We don't charge our colleagues.
okay. Okay. Arvind?
Shall we wind up,
Fine.
sir?
Yeah,
Yeah.
yes,
I
Arvind.
think we've had a very
One homework
interesting
for
discussion.
Arvind before we wind up. So, Prabhakar mentioned about Tai Chi. I think probably we've been missing on this aspect in our discussions and in our programs. So if you can get an expert and so we can get some useful information, and then probably we can start Tai Chi or some challenge related to it.
Sure, sir. In fact, we actually did
No,
a event some
Can
time
I add a
ago.
point, Arvind?
Yes,
Arvind,
sir.
I'll add a point. Don't do all this. Go to just Instagram and just put Tai Chi. You'll get all those exercises. It's very, very simple.
So many variations, Prabhakar.
No, nothing. Very simple ones.
A lot of
What you can do-
advertisements and variations. You don't know
Don't
what is
try.
really right and scientific.
I'll post some in your group. Don't worry.
Okay.
The கைய கால ஆட்டலாம் சார் தாய்ச்சி ஆயிடும் அவ்வளவுதான் அப்படின்றார்.
அவ்வளவுதான்.
இன்னொன்னு அவன் பேசுற ஸ்பீட்ல பேசினாலே போதும். If we all have 80 to 90 words per minute, he talks in 160 to 270.
Tachycardia, sir. Tachycardia மாதிரி. Beta blocker போட்டுறலாம்.
Shall I summarize what was discussed here? So I guess a lot of myths got busted and a lot of conventions which we had are of course very old. But seriously speaking, I think early screening, basic screening at the first level, looking at cholesterol levels and specifically LP, small a, ApoB, these are the new markers. And then when in doubt, I think that was a very valuable point Dr. Prabhakar said. When in doubt, do not delay. I think we have enough instances of doctors who said they will go to the doctor after their surgical list was over and they never actually got to the cardiologist. Illa, Dr. Kasi? So I think
And don't drive.
Don't drive, don't delay. I think that is our take home today. And do not try self-medication. Do not jump into tests. The most basic things, I think, have a higher value. Treat hypertension from lower levels of 120 to 129, anything over 90 millimeter diastolic. HbA1c, pay attention from 5.5 itself. For people who are into endurance training, long distance running, please pay attention to warning signals. Hydrate well, warm up well, look at your electrolyte profiles, do regular training before you jump into it. Marathon is not something where it's just a photo event. I think it's a long preparation for the final execution. And for, of course, screening levels also, pay attention to your LDL levels very strictly. And very pertinent was waist to height ratio. We usually look at waist to hip ratio, but the waist to height ratio, I think, was a very new concept. So I hope I got most of it. I also post these minutes in our groups tomorrow for the people who are missing the session live.
Finally, Arvind, you should add, don't worry, be happy.
சார் அது எவ்வளோ ஈஸியா இருந்தா நம்ம வெபினாரே நடத்த வேண்டாமே சார்.
You have to make yourself happy. I think that's
Arvind,
very, very
tomorrow I'll post the YouTube link in all the groups.
Sure, sir.
Sure.
One thing
Sir,
which I
I-
started doing after my event is spend 1 hour a day with your body. It can be either walking or exercise or play badminton, something like that. Spend 1 hour with your body, 23 hours, the body will take care of you. That I made it mandatory post my event.
Great.
One thing is, Prabhu should
Yeah.
be happy in the mind without any stress, beyond everything. Because I'm the most sedentary fellow, walking less. You know what you all do for 1 day, I do for 1 year. So, but I think you must be very, very happy and relaxed, whatever may be the stress.
Nirmal, I think you should have a Tai Chi program with upper body exercises for Chandrasekhar specifically. Sponsored by TNOA.
At TNOA, at
Tai Chi
TNOA,
also.
go away. We'll do that also, Arvind.
He compensate with sleeping, Prabhu.
I sleep very less.
You
Sir,
don't
I'm
sleep.
sure he has a lot of mental miles he accumulates. His mind works at a different pace. We have to catch up when he's mentally active.
Prabhakar said, no, I sleep for 5 hours only. That is the truth.
No, that is deep sleep. I know how difficult it is to wake you up.
It's the Brunei experience.
Yes, yes.
Guys, at the end of it, I should say thank you so much for all the wonderful questions and the wonderful experience. Nice catching up with Nirmal. It's been quite some time actually since I caught up with Nirmal. And you will be surprised to know that this is the longest time me and my brother have spent together. Surprisingly.
You're forced to have a heart-to-heart.
So thank you so much. Thanks, wonderful for the
Our
wonderful.
president is
Thank
there.
you so much.
Sujata madam, you're there? No. Okay.
Remarks.
So thank you so much, Arvind, for really making it a beautiful, useful program. It will be there for a very long time. And thank you, Dr. Raj Anand and Dr. Kasi, for your wonderful inputs. VRV sir, our president-elect, and of course Nirmal, as usual, Vlas, and our president and everybody else who have been on board. And I think it was a wonderful program, awakening program. Very lot of take-home points. Prabhu, thank you so much from the bottom of our hearts to you.
Thank you.
Yes,
Thank you.
Arvind. Yes,
Thank you,
Arvind.
Dr. Prabhakar. Thank you to the panelists, Dr. Raj Anand and Dr. Kasi, for coming out with their stories. Not always easy to share your personal experiences with the
And we
public.
had our editor of Tamil Nadu Journal, Dr. Prasanna Venkatesh, also, in spite of his very busiest international assignments. Thanks, Prasanna.
Sir, thank you, sir. Sir, Kasi, sir, thank you for sharing your story, sir. It was very inspirational, and the moment when they placed the stent and the pressure got relieved, I've heard few people say that, but thank you for opening up with that story, sir. Thank you, sir.
Thank you. Thank you.
Yossi should also have some cardiac awareness thing. According to Dr. Prabhakar, Yossi guys are not free from any cardiac risk.
Sir,
Most of their hearts were somewhere else, Arvind.
sir, for me,
Yossi
it's on
people
the
are happy, Spa.
Sir,
Yossi
for me,
people
it's
are
on the
always
right,
happy.
Sir,
I
for the
think
record, for
Manju
me,
can
it's on.
stop the recording.
Yeah.
So,
Yeah. You can stop live sharing also. Yeah.
yeah,
Sir,
yeah.
Okay, doctor. Okay.
as Chandrasekhar sir rightly told,
Wait,
I'm a
man.